Well, good morning. Well, good afternoon, depends on where we are. I am Catterina Ferreccio. I am a medical doctor and epidemiologist. I've worked in infectious diseases in Chile for many years, but in the last decades, I've been working on cancer and infection. And I have been in charge of the COVID-19 advisory group during the whole pandemic. So I will be very happy to share with Dr. Collins his experience, and I'll ask him to introduce himself and also tell us what are the good and the bad things that he sees from his point of view. Thank you.
Well, thanks, Catterina, and I guess we're going to be friendly, so please call me Francis. And hello, everyone, whatever time zone you're in. Honored to be part of this IHCC summit and this panel discussion between two of us. And after 20 minutes or so, we'll be ready to take your questions. So feel free to start putting them in as soon as you have something you'd like us to address. Yes, I'm Francis Collins. I served as the NIH director from 2009 until a little less than a year ago when I stepped down in December of 2021, which means that I was responsible for an awful lot of the response to COVID-19, along with many other colleagues here in the United States. I'm currently in the White House as a special projects advisor to President Biden, but continuing to run my research lab at NIH that works on diabetes and on a rare disorder of premature aging. But there's so much we could say about this topic of what went well and what didn't and what lessons we should learn. Just quickly, and then I'll ask you the same question, Catterina. In terms of what didn't go so well, we got off to a rough start in the US. I think it's well known the initial efforts to set up testing did not go well, and we lost some time there until ultimately reliable tests were developed. But even so, those tests were generally requiring a centralized laboratory, and the turnaround time for getting answers was not what you really would hope for in a pandemic where you want to know right away if somebody is infected so that they can not infect others. And that got a lot better with investments in point of care testing, which is, of course, now the case where lots of people are testing themselves at home, even today. And I wish we had had that at the beginning. It might have reduced the transmissibility. The clinical trial efforts in the US did not get off to a great start either. There were a lot of well-intentioned but underpowered, sort of scattershot clinical trials. Many of them focused on one thing, hydroxychloroquine, which turned out not to really have value. And it took a few months to pull together a more organized effort to develop master protocols, to prioritize what compounds were most likely to show benefit and to get them into rigorous trials where you really could trust the results. And I guess in terms of our public health messages, we also had a challenge there in terms of trying to do the best we could with very rapidly evolving information about SARS-CoV-2. I think probably we'd have done better to make it clear all the way along that when a recommendation was made about public health, it was the best we could do at that point, but that it was likely over the course of time to change because, after all, we were learning more about this virus all along, and we certainly hadn't anticipated all the new variants that came along and made it necessary to keep changing the documentation. And unfortunately, this set the stage for a lot of misinformation and, frankly, some really intentional disinformation, which got people confused and polarized and did a lot of harm, I think, to what potentially we had hoped to see happen, which is to have public health messages embraced by people in a way that would actually lead to changes in their behavior. And we sadly lost many lives because of that, people who decided to pass up the opportunity for free vaccines that had been shown to be safe and effective in rigorous trials. So yeah, that was rough. What went well, certainly the vaccine development, particularly the use of the mRNA platform, just unbelievable speed achieved there in terms of having phase 1 trials started 63 days after the sequence of the virus had been put on the internet, and having rigorous phase 3 trials for the mRNA vaccines, revealing remarkable efficacy, over 90%, and a very good safety record, just 11 months after the initial recognition of this pandemic, which is about 5 times faster than has ever happened before. So that went really well. And I think the international collaboration went well, but could have gone better. We talked a lot to our colleagues. We shared information about trials and surveillance, but everybody was working awfully hard just to try to keep up with what was a rapidly changing situation. So there are some lessons there as well. So that was probably too long, but I could go on much longer. Summary of what went well and what didn't. But Catterina, from your perspective there in Chile, what went well?
Well, I think you did a great summary. Well, it's the what I would say what went wrong was similar. We didn't have tests. Especially we have a very important heterogeneity along the country. You know, we are like 4,000 kilometers long and very narrow. So in the big towns, we did have, but in some cities, they didn't have access to diagnosis. It could take 2 weeks to get the result. So it was impossible to do. And at the beginning of the pandemic, we were very strict to what was called a COVID case. So the contention was a failure at the beginning. Also, the government didn't agree with our recommendation of isolation of the first cases that occur in the country. So we couldn't do a contention, and we had one of the largest outbreaks worldwide in relation to the population and one of the highest death rates. And the other problem was that people couldn't isolate even if they wanted, because in Chile we have a very big population that lives with high density inside the houses, very small houses. So we discovered that the main focus of infection were the households, and was outbreaks in whole buildings. So these buildings that we call the ghettos, because we call vertical ghettos. So that required to move people to external houses, and that was a good thing. The government provided places for people who couldn't isolate in their household. But the effect of that is what we saw, a very high socioeconomic difference in the risk of dying of COVID in Chile, and it's still maintained. So that was the problem. The other problem was that we were in the middle of very important social crisis, huge crisis, very serious. And population didn't believe in the politicians, in the police. So the scientists became the only voice they could hear. And that was a very important responsibility for us. And today, in recent surveys said the organizations that they have more confidence are the universities. So that was very important, because the universities, through the new Ministry of Science, took control of the information. Because the people, the same as you said at the beginning, was a lot of fake news, and the government, the first Ministry of Health didn't want to share the information. So that became very suspicious. But then the Ministry of Science was a leader in getting the universities agreement to analyze the data. So we did analyze the data, and then the population began to respond, and the non-pharmaceutical measures that we were proposing were very well received. Everybody was using masks and isolation, and people didn't go out. So we really have a good response, and I think in great measure because the university analyzing the data, and we were every day on the news. We answer radio, television, whatever, and all the universities we joined together. It was very easy for scientists to collaborate in our country, and we didn't we hadn't done that before a lot, but this was the first time that we do in this massive way and had a very good effect. That was, so I'm telling the good and the bad. And the other very good thing is that we did have vaccine very early as the US, but we had the Chinese vaccine, Sinovac, the CoronaVac. I had 3 CoronaVac shots and 1 Pfizer. So because the first that we had was that vaccine, and there was a situation in which in my university there was a group developing the PRS vaccine with the Sinovac laboratory. They were collaborating. So it was already a relationship there that allow us to have a very early access to the CoronaVac vaccine that was not as good as the Pfizer, as you know, but was around 80% and above to protect against hospitalization, and that was excellent in that moment for us. So I would say that in summary that we have similar problems like you, but our social crisis and socioeconomic differential make us took us to have a very high mortality at the beginning of the pandemic, but then today I think the average we are not so bad. For many months we were one of the worst together with the US, I think, in high mortality at the beginning.
That's really interesting to see the similarities and the differences for sure. Can we talk about the international collaboration a minute here, Catterina, since we're here at the IHCC? Just from my perspective at NIH, some of those international partnerships were incredibly valuable in understanding the course of the pandemic and the willingness, for the most part, for people to share data very rapidly in the form of preprints. I think preprints were really important in this pandemic. You had to be a little careful because they weren't yet peer reviewed, but you get information so much sooner that way. I could give a shout out particularly to the UK and the way in which for clinical trials, we talked a lot back and forth with their recovery trial, which was so quickly put together with the national health system and able to look at hospitalized patients and figure out things like the value of steroids in preventing a terrible outcome in the sickest patients. And I also give a shout out in terms of surveillance to South Africa, because so much of the evolving nature of this seemed to be discovered there first. And I had many Saturday and Sunday conversations with Glenda Gray and her colleagues at the South African MRC, where they were willing to tell us exactly what happened like 3 days earlier. And almost always it was a little snapshot of what the rest of the world was going to see. So that was really amazing. They were completely willing to do that, even though at times it resulted in South Africa being criticized and people shutting down travel because they were talking about what they knew when other people didn't even know it quite yet. And another shout out, I guess, in terms of really understanding the evolving nature of the pandemic and whether vaccines had durability or not, or whether boosters really were needed, it goes to Israel, because they were one of the first countries to have really widespread mRNA vaccination, but also to track and see what happens. And the fact that now many countries are in fact insisting on boosters, although the public hasn't necessarily embraced them the way we hoped, comes out of that Israeli data, which was so carefully collected. So we would have been really much worse off without that traditional but very important interaction of scientists in all countries with each other to say what they know. How did that play out for you there in Chile? Did you have access to information when you needed it?
Yes, absolutely the same like you say. With the MRE access was very important. We were reading everything that was there. We had meetings with the Chinese from Wuhan who were treating the first cases. So we had a lot of opportunities with WHO. And also I am the leader of a cohort, the director of the MAUCO cohort in my country, that is a cohort of of chronic diseases. But we immediately, I applied for some Chilean funds. So we began to do a surveillance of COVID in the town we are like a Framingham little court in a town and also in the court. And I'm collaborating with GovNet, so we send samples for them. We have a collaboration with NIH actually there for cancer, but then they move also to COVID. And also with CDC, where CDC was interested in studying the effectiveness of our vaccine schemes that was CoronaVac and then Pfizer. And we have 4 doses, most of the population. So we are doing currently effectiveness evaluation. It's very interesting because the 4 dose is much more effective than 3 doses. It's completely different. It's really like a jump. Well, also the 4 doses tend to be, was Pfizer mainly. And so it's impressive, and it's still more than 6 months still lasting. So I would like to see more time before putting the other booster, but it's already recommended by the government. Yeah. But we saw, we were updated. We were always updated with what was going on with the trials of vaccines and drugs. And until now, we are still discussing Paxlovid and things to be recommended or not. And I think science played a very important role because we are, in this moment of crisis, we are the only, sometimes with some countries, we are the only linkage scientists. Yeah.
Indeed, and it's troubling to see in many parts of the world, certainly true here in the US, that distrust of science has actually grown at the very moment where science probably had the most to offer to save lives. And yet again, because of polarization and misinformation, scientists actually came under attack by people who just didn't like the messages they were hearing. Yeah. Just in terms of surveillance, I'm curious, Catterina, one of the things I learned during this effort was if you were really trying to see what's the course of the pandemic, you could look and see what was happening with people in hospitals. And obviously that was a very specific and worrisome sign, but it was often weeks after the initial outbreak was really getting serious. And if you wanted to quickly respond, that was a little bit of a late guidance to have. Wastewater surveillance, I found, was probably something that we had not appreciated fully until this pandemic. And maybe that's a lesson to learn for the future, because if you look at the timing of when an outbreak is starting to happen in a particular location, it was wastewater surveillance that seemed to be the very first indicator. And now we're seeing it in things like polio, which once again, we seem to be seeing in the US, which is just horrible to contemplate, that wastewater was the first indication that this virus was back in some parts of New York. So is wastewater surveillance something that Chile has also invested in, just thinking about the future?
Yes, we have discussed that also in our advisory committee. At this moment, it's very expensive. The water companies are all private in this country. So at the beginning, the first study was very complicated and expensive. So, and since we had so many cases at this point, was like, well, in this moment, it will not add much because we had a lot of information. But but for the future, as the pandemic, the cases go down, and when you think, I think it's a good thing to consider for surveillance when you are apparently in a lower burden. But when you are with a high burden, it's like will not add too much. It will add when you don't have so many cases. But if it was cheaper, I think it has to be cheaper. It's too expensive at this moment.
Yeah, maybe point's very well taken. We have to figure out how to make that technology more readily achievable at an affordable cost. So I see we are now in the sort of last 10 minutes of our brief panel here, and I see questions are popping up in the chat box. And I think the first one is to you, Catterina. Can you see the chat?
Yes, I can see. Ask what is the recommendation? One recommendation to address the misinformation and fake news in future pandemics? Well, I think the first is to share the information with the public and share the uncertainties and the rationale for the decision that you are taking, and invite, for instance, I've been advisor from a rightist and a leftist government. And so it's good that you take people that are technicians that can go talk with the right and the left, and especially when the country is too polarized. You have to find people that can be credible, politically credible, and show the data and show the certainties. I think it's the only recommendation.
Yeah, I wish that we had had more success with that in the US as well, where the conspiracies that spread rapidly on social media seemed to somehow get into people's hearts and minds more quickly than the actual public health information that was based on science. I think some of the things that we might want to think about in the future is whether there's a way to build a better network of sharing scientific information in trustworthy people who could be sort of representing the scientific perspective, as opposed to having it all seem very top-down from government sources, which at least right now seem to be under some skepticism in a lot of people's minds. So if we had a network, I mean, let's empower every high school teacher and every graduate student to become a source of information that people might resonate with, because these are people that are in their community, as opposed to somebody who seems very far away and maybe not really in touch with what they're experiencing. Maybe also somebody has said that of all the things that were the worst sources of misinformation and disinformation, they were all kind of predictable based on past experiences. And maybe there could have been a way to prepare for that, sort of tell people, look, when you hear that in fact, this vaccine has a chip in it that's going to allow Bill Gates to track you around afterwards, don't go for that. That's the kind of conspiracy that you might expect happening, but you can look at it right now and see that it doesn't make sense. What you call pre-bunking instead of debunking. That's a hard thing to do. Maybe we need to think about that in the current climate where this kind of information spreads so rapidly and people don't know what to make of it. You have trouble competing with the latest posting on Facebook that everybody spreads around because it stirs everybody up.
Yeah, it's true.
And there's another question to both you and me, how the pandemic has contributed to building genomics testing infrastructure that didn't exist. Well, I'll quickly comment on that. In the US, the Congress actually provided additional funding to NIH to try to really accelerate this process of having better testing infrastructure. And that led to a program called RADx, Rapid Acceleration of Diagnostics, which is largely responsible for the fact that there are now lots of home testing available in the drugstores. They aren't as cheap as I wish they were, but they are affordable for many people. And in fact, it's made it sort of difficult now to track the actual course of the pandemic because most people are not going to central labs. They're testing at home and they're not reporting the results. So we don't really quite know how many people have tested positive today. It would be better if that had some link to some reporting, and we're trying to see something about that, but it gets into privacy areas. So I think the other thing I would say about this, but then Catterina, your view is that these platforms that were developed for doing point of care testing for COVID can be adapted to other things too. Right now, a passion of mine is figuring out how we could find and cure the people who are infected with hepatitis C, but we don't have a point of care test for hepatitis C, even though we have a safe and effective cure. So maybe the same platform that was developed for point of care testing for COVID-19 could be used for other diseases like hep C, like Lyme disease, like a long list of other things where the testing is still kind of clunky. Wouldn't that be a good thing?
Yeah, well, thank you. Well, I want to mention that we have a very nice politics now. The government put a very cheap antigen test in some pharmacies. The government offered at a very cheap price to the pharmacy that accepted, the private pharmacy that accepted to ask the client to enter their ID and the symptoms, and so they will pay 3,000 pesos. Normally it will be 12,000 pesos.
Huh.
So if you want a cheap test, a cheap test, you have to enter your ID, and then you have to answer if you got positive or negative, and the contact, and it's working. And it's working. So you can get in touch with our government, our ministry. I can, if you're willing to say. So this is one of the effects of the availability of the genotyping. This is not genotyping, it's antigen testing, but the development of this infrastructure is very important because now we know, and the government know how to create a chain of private pharmacies that can provide information in exchange of some money. Yeah, that was very nice. And yes, for instance, monkeypox was very quickly. The test was available all over the country. We had some cases, we had the deaths, but it's completely under control because it occurred in this infrastructure, active infrastructure. Yeah.
Very good. I see we have one more question at the end of this, and then we got only a few minutes. What is your sense about our preparedness for the next pandemic? Would we do better? Catterina, what would you say to that?
Well, for the monkeypox, I think we're doing better, much quicker. I mean, imagine what would have been. I think WHO made some mistakes at the beginning that we have not discussed, like the ignorance of the air transmission that lasted too long, 1 year, and there was a discussion if using a normal mask. Also, the need to have countries to avoid travel, the decreased travel, I think was important at the beginning because we didn't know how to treat the cases. So every time, for instance, the poor countries, any day was better to avoid the entrance of the virus because the world was learning. Remember, it began in Europe, so we didn't need to go too quick in having this big dissemination. But WHO was not enthusiastic with that. They didn't want, they didn't want to declare the pandemic. Then they didn't want to stimulate the travel limitations. And that, I think, was not good. But I hope now with they have done a self-evaluation. And so I hope that this will find us in a better place the next pandemic.
Yeah, I agree with that. In terms of the science that we might think about doing to prepare for the next pandemic, and we know there will be one, it is possible, I think, once we identify what are the most likely pathogens, to go down the road of beginning the process of developing the first stages of vaccines development, so you don't get caught completely off guard by whatever the next one is. Likewise, with antivirals, we could start down the process now of having that difficult and challenging effort underway in a pandemic preparedness mode. And a lot of us are hoping to see the funds provided to make that possible. And then in terms of surveillance, I think it's really going to be critical for the whole world to be empowered to do that. One of my current passions is working with colleagues in Africa to try to see what could be done across Africa to come up with centers of excellence in genomics. And Nikki Mulder, who I think is talking tomorrow, I might say more about that, because I think this time is right to really empower the whole world with genomic capability, both for pandemics, but also for other things like cancer and common disease.
Yeah. Okay, we agree.
I think we have reached the end of this very brief 30 minutes. Catterina, thank you. It was nice to chat with you in this circumstance. I hope people listening got something out of this. I did. And really, congratulations on the way that Chile faced a really big challenge in those 4,000 kilometers and figured out how to address this with the best science. So nice to chat with you.
Well, thank you, Francis. Nice to meet you. It's an honor to share with you.
All right.
I hope to see you again.
Okay. Thank you, everybody.